Today we're focusing on the fluid intervention, and I'm delighted to announce that we've got our intervention lead here, Dr. John Silverside. So we'll be running through some slides. We are planning to record the session as well, so it should be on our website soon after this, and on our YouTube channel. So we've got some slides to run through, and then we've included some common FAQ queries just around the fluid intervention, few study updates too, and then we'll open it to any questions. So anything you want to ask later on. So do you want to go ahead and start recording, Ravi? Is that okay?
Yeah, I've hit record.
Perfect. Okay. Okay, here we go. Over to you, John.
Great. Okay, thanks very much, and thanks everyone for joining. It's nice to be with you. I guess the purpose of today is really just to hopefully address any queries you might have around the fluid intervention as part of SepTiC. So I'm going to give a little bit of background, why we're doing the trial and what we're trying to achieve, I guess. I don't really want to run through every single detail because you can read the protocol at least as well as I can, but hopefully answer some of the obvious questions and give you sort of try and explain the philosophy behind it. Okay. So next slide, please. And by the way, if you want to interrupt and ask any questions, that's absolutely fine. So just stick up your hand or just talk. Yeah. So there are four real research questions in the SepTiC trials. So we're really talking about the second of these. And the question is, does conservative fluid therapy with active removal of accumulated fluid or deresuscitation improve outcomes compared to standard care in patients with sepsis? So some of you may have seen a diagram like this before. So this is trying to represent the different stages of how we manage fluids in sepsis and other critical illness states. And assuming you have some background in critical care, you'll be very familiar with this. So the rescue stage, if you like, is, and there are different terms for these things. These are just fairly arbitrary names, but and in truth, patients merge from one to the other and sometimes back again. So this is very much a conceptual idea. But if you imagine the rescue phase, so imagine your patient who presents really unwell and they're hypotensive perhaps, or they're shocked, and you're plugging in some fluids and somebody's squeezing a bag. Okay, that's the initial rescue phase. Let's try and get some measure of stability here. And then the optimization phase is the bit after that, the bit that, yes, maybe they need a little bit more, maybe they don't. Maybe we do some tests to try and find out and predict whether the patient will respond to fluids. And then there's the stabilization phase where we've stopped giving fluid resuscitation. Maybe we're starting to feed the patient and maybe the IV fluids have come down. And then de-escalation is when we come along and go, well, this patient's really overloaded. We should offload some fluid and we'll de-resuscitate or de-escalate, often by giving diuretics, or we'll dial up the fluid removal on the renal replacement therapy. So those are the four phases, if you like. And next slide, Janice, I think, sorry, I'm going to come back to that, but I think we're really dealing with the last three of those stages, okay? There's lots of evidence that if you give people lots of fluid, or if you have accumulation of a positive fluid balance, that patients do worse. So this is in patients with acute kidney injury on renal replacement therapy. And next slide, I think there are other examples from renal RRT studies. Next slide. This was surgical patients, and keep them coming because there are a lot more of these. That's sepsis, and I'm sure we have some more acute kidney injury. There's an endless list of these studies showing a strong association between more fluid accumulation and adverse outcomes, including mortality in sepsis and AKI and ARDS and all sorts of other conditions that bring you into the ICU. One of the landmark trials really was the FEAST trial, because up to this point, we'd all shown that more fluid is linked to badness. It's associated with badness, with bad outcomes. But we never really had any definitive evidence that that was anything more than association. So if you get more fluid, it's probably because you're sicker, and therefore you're more likely to do worse. Okay. This was really interesting. Now, this is a study in African children with severe infection in sub-Saharan Africa, and many of them have malaria. So it's not directly comparable to the kind of patients that we see every day, but still. So this study was designed to show that rapid fluid resuscitation saved lives. And in fact, it showed the opposite. So it showed that rapidly resuscitating shocked children with either albumin or saline increased mortality compared with a slow, gradual restoration of fluid balance. So that showed that what you do with fluids can really make a difference. It's not entirely clear how we extrapolate that and interpret it in a UK context, but it does show proof of principle that what you do with fluids matters. Next slide. Okay, next slide again. Okay, so since then, over the last few years, we've had another number of randomized trials looking at this question of what you do with IV fluid resuscitation in sepsis. There's the Clover study, the Classic study, and the Andromeda Shock trial. So these are three large trials, and they're all looking at slightly different questions. And essentially, they have not shown a difference, statistically significant difference on patient outcomes based on fluid resuscitation strategies. So the first two compared restrictive versus liberal. The Andromeda Shock was a little different, and they compared two different targets, so either capillary refill guided fluid resuscitation or lactate guided resuscitation. So why did they not make a difference? Well, they tried to address only one of those four phases that I talked about at the beginning. And I'm going to show you what we're trying to do is a little bit more comprehensive and might have more of a chance of making a difference. This is a systematic review that we did back in 2017, so a few years ago now. It didn't include all those studies, but it did show a strong suggestion of higher mortality in patients given more fluid. Next slide, please. Okay, so where does the fluid come from? Well, we tend to think of fluid being given in a hurry, the rescue phase, if you like, and maybe the optimization phase when we're titrating fluid to effect. But in practice, it's actually a lot more, a lot less exciting than that, really. A lot of the fluid comes from the day-to-day stuff that we don't even think about. So both of these studies show that a lot of the fluid comes from maintenance. Some of it comes from nutrition, some of it from drug volumes, and only really a minority comes from the conscious administration of fluid boluses designed to improve tissue perfusion. Next slide. So to recap, these are the four phases that have been described in literature. They're kind of arbitrary, but these studies try to address different phases of that continuum, whereas SepTiC and the RaDaR2 study, which preceded this and was the pilot, are trying to address the latter three phases. So everything from the optimization phase onwards, right through to the de-escalation or de-resuscitation phase. When I mentioned RaDaR2, I can see one familiar name on there. I know Sunderland were a site for RaDaR2, so you're very familiar with this. This was our feasibility trial, and that was published in ICM, I think it was 2020, not 2019. Anyway, so this is kind of the prototype, if you like, the pilot. And here we were trying to establish the feasibility of whether we could deliver an intervention to reduce fluid accumulation and offload or de-resuscitate excess fluid. Next slide, please. And I guess the reason we're all here is because we could. So this shows separation between the two arms of the trial in terms of fluid balance. over time. On the graph on the left, we've got the daily fluid balance, and you can see that there was a difference here between the two arms on days 3 and 4, and that results in a separation of cumulative fluid balance over time in the right-hand graph. So if we look at that, the control group, the usual care group in that study, showed a gradual, slow accumulation of fluid over days, whereas the conservative group, we were able to reduce that fluid balance right down to nearly neutral by day 5. These are the figures around that, and we can see that it was statistically significant. So it demonstrated feasibility of the study intervention. And this was carried out in 6 centres around the UK. Next slide, please. Adverse events. So our safety outcomes included looking for specific adverse events, and not perhaps terribly surprising that we found hypernatremia and metabolic alkalosis were common complications of diuretics. That's pretty well known, and were higher in the intervention group than in the usual care group. Importantly, cardiovascular stability was similar between the two groups, and rates of acute kidney injury were similar between the two groups. So there was no evidence of any harm in terms of cardiovascular or hemodynamic instability or of renal outcomes, acute kidney injury. There's obviously a lot of clinicians who worry about these things, and that's understandable, but there's no evidence from our pilot study, RADAR 2, or any other study to suggest that restricting fluid worsens renal outcomes or indeed cardiovascular outcomes. So on to SepTiC. Well, unless anyone wants to ask any questions at this point, we'll move on to SepTiC. That's giving you a bit of the background. I'm conscious we skimmed over a lot, so if there's questions, that's fine. If not, SepTiC is really designed to be the definitive trial, and it's answering to answer those 4 different questions I showed you at the start. But the one around fluid is around the comparison between conservative fluid management and deresuscitation compared with usual care. Inclusion criteria are the same for the first and second trials. We're looking for adult patients admitted to the ICU due to suspected sepsis and expected to stay for at least 2 calendar days. So if they're intended or expected to still be in ICU the day after tomorrow, then that's fine. We all suffer from optimism bias. So we all think our patients do better than they really do. And you'll know as well as I do that if you ask a clinician, is the patient going to still be here in 2 days' time? They'll say, oh, no, they'll be much better. They'll be out of here by then. And in reality, it's quite different. So that's just, there has to be a realistic, an element of realism applied here. They should be receiving intravenous antibiotics for suspected sepsis. So if that's the inclusion criterion, and then we want them to have received adequate initial early fluid resuscitation. Now, that does not mean that we think the patient will not need any more fluid. It doesn't mean that some mythical state of euvolemia has been attained and proven, because that, well, I don't think it exists. But what it does mean is that that initial rescue phase is over. So you don't need to squeeze in a bag of fluid right now. That's essentially all that we're asking for. And that might look like 30 mils per kilogram, or it might not. That's the figure used in the surviving sepsis guidelines, of course, but it doesn't have to. All we want is that the patient has achieved that some measure of stability following the initial administration of fluid. Okay. If any questions about that, happy to answer them. And then that's our suspected sepsis definition, which is standard. Okay. But essentially, if you're in ICU and because of what somebody thinks is an infection, the chances are you'll meet the definition. Exclusions. If you're more than 24 hours since the ICU admission, you're out. And that's because we're trying to intervene early and reduce the total exposure to fluid overload. So we want to intervene early and prevent it, as well as treating it when it occurs. The first admission due to sepsis, and obviously patients who are not expected to survive 90 days are out. Those who are not expected to survive initial resuscitation are out. Neutropenia if it's due to chemotherapy or malignancy. So that's a very specific population, and
between 7 and 7:30 a.m.
7 or 7:30.
okay. And if you have an unusual infection that sort of requires prolonged antibiotics, that's an exclusion, as is DKA, HHS, diabetes insipidus, or subarachnoid hemorrhage in the last 21 days. So these are patient groups for which there are specific fluid guidelines. We could talk about whether those are correct or incorrect, or evidence-based or not, but that's beside the point. There are specific strategies for fluid for those patient groups, so that's why they're out. And then patients who are less than 40 kilos, because obviously the different considerations may apply for that patient group. Okay, so the intervention is conservative fluid and deresuscitation. So it's essentially two things. One is giving less fluid, and the second is treating any fluid overload that has already occurred. So the first of those, the conservative fluid administration strategy, happens from as soon as possible after randomization. And the idea is that once that initial early hypovolemia has been corrected, and that's generally within the first hour or so, that's the phase when we're trying to rescue the patient by just trying to maintain some kind of perfusion with the first little bit of fluid. Then after that, we want you to only give fluid boluses of 250 mils at a time if there are overt signs of hypovolemia. And really what we're looking for here is evidence of hypoperfusion. So skin mottling on the knees is the most sensitive part, believe it or not. So skin mottling beyond the area of the kneecap. And I think there's a diagram coming up that shows you what we mean by that. And then a patient who's, if the blood pressure target can't be maintained despite dialing up the noradrenaline or other vasoactives, then that can be a sign that the patient's hypovolemic. If the serum lactate is greater than or equal to 3, or if the urine output is less than 0.25 mils per kilo per hour. These are the criteria to suggest when we think the patient might be hypovolemic and when you can consider giving a fluid bolus. You're not mandated to give it, it's a consider, okay? But we do really want you to reassess after each time. So if you've got to, if it's not making a difference, and particularly if you've got to a liter, it's not making any difference, then stop. It's probably not going to work. I often talk about the definition of madness, which is doing the same thing repeatedly and expecting a different outcome. And it applies really well to fluid therapy, because if we all think that the fluid bolus that we're going to give is going to work much better than the last one and the time before that. Yes, we're essentially looking for response, and if there's no response after a few fluid boluses, then you have your answer. It's not going to work. Try something else. We want you not to give maintenance fluid in the conservative group. You can give normal feeds as much as you like, but no maintenance fluid. But you can replace blood or any other measured fluid losses, for example, from surgical drains, which are maybe of a high output, or high output stomas, that kind of thing. So we don't want you to ignore fluid balance, but we would like to avoid the sort of, I guess, thoughtless administration of fluid, which can sometimes occur when we just put patients on maintenance fluid and then forget about it. Next slide. Okay, so that's from randomization onwards, and it applies right through to day 5. That was the conservative fluid part. And then on days 2 to 5, we want you to do a little bit of thinking. And this is not dissimilar from what clinicians do every day anyway. It's not something completely new. It's really just protocolizing it a little bit. So the idea is that if, first of all, there are 2 questions. So is the patient stable? And do they have signs of fluid overload? Okay. And if both of those criteria are met, then we want you to give diuretics. If the patient's on renal replacement therapy, you take off fluid using the RRT instead. So by stable, we define that as noradrenaline or norepinephrine less than 0.2 mics per kilo per minute and not increasing. And that's a pretty simple definition. And if there are signs of fluid overload, we define that as more than 3 liters cumulative positive fluid balance from ICU admission, or if there's edema in more than one site, that can be arms, legs, flanks, abdominal wall, chest, or on the chest X-ray, then that's the indication for deresuscitation. Okay, so the idea here is to reflect what we as clinicians do in practice. So our first question is the patient stable? Patient stable. Do they have signs of fluid overload? And if they do, that's when we would initiate deresuscitation. Okay. And the combination, excuse me, is indapamide and furosemide. We've chosen indapamide because there's a little bit of evidence that it helps with natriuresis and prevents hypernatremia. You can use a different thiazide if you want, doesn't matter. The important thing is that you give one along with the furosemide, as long as there's none of these, there are no IV preparations, so you have to have access to the gut for that. And then a furosemide bolus followed by an infusion, and that's titrated to effect. I meant to change these slides, so actually there isn't a predefined algorithm. We want you to titrate it to effect. Okay. And the aim is to get a negative fluid balance of about 1 liter a day. If they're on renal replacement therapy, you do the same thing, but you just dial up the fluid removal instead of using diuretics. And the idea is that you assess this every day. So each day, questions are, is the patient stable? If they're stable, do they have signs of fluid overload? And if they have both of those criteria, then that's when you give deresuscitation to remove the accumulated fluid. And once they've reached their target, they're no longer fluid overloaded, then you stop. Okay. Next slide. So this just puts this in a flowchart form, which is a little bit small. So sorry, yeah, move on to the next slide, please. And yeah, and so throughout the trial, remember that if there are objective signs of hypovolemia, then you can consider fluid administration, the 250 ml bolus. Okay, so we don't want to, we're not trying to stop you giving any fluid ever. We're trying to make you think about it and give it only when there's an indication to do so. I see a hand up at this point, so Ashley?
Hi, John. I just wanted to ask about the fluid deresuscitation. So after the IV furosemide bolus, do we immediately, start the infusion, or whether we will, check for, any chance, any, BP going down or noradrenaline increasing, or do we immediately start the infusion straight away?
So you're not, I mean, we leave a little bit of discretion, but generally I would just start it. Any infusion, it's normal to give a loading dose and an infusion to follow. So I would just start it at that point. You can always stop it again. You can titrate it up or down as needed. I suppose the exception is if you have such an amazing response to the first bolus that you think you're already going to hit the target, then you can wait and see a little bit. No problem with that. We're trying to make this as pragmatic as possible and not stipulate everything down to the nth degree. So you have a little bit of leeway to make a judgment. But I would generally encourage you just to start it.
Yeah. Okay.
Yeah.
Okay. So we'll be monitoring the blood pressure and the NORAD, and also looking at the fluid, in the urine output, for a couple of hours, and if needed, and maybe
Yeah, I
infusion.
mean, I would encourage your clinical teams to do what they would usually do. So we're setting a target. We're telling you roughly how to get there, and the detail of that, I would leave to clinical teams as much as possible. I appreciate it'll vary a little bit between sites, and yes, it does need a close eye, but you're unlikely to be able to do a lot of harm with this. We know that in principle the therapy is safe, and I guess I mean, in normal clinical practice, you'd expect that if the patient is 4 liters negative and their blood pressure is 70 systolic, that somebody would say, should we turn off the furosemide? So I think just close liaison with the clinical team is really the key here.
All right, thank you, John.
Okay. Yes, can I just point out the mottling score? So, well, everyone's needs may differ, but broadly speaking, if you imagine the area over the skin area over the patella, then outside that area would constitute mottling score of 3, 4, or 5, and that's a criterion for possible hypovolemia and therefore for considering giving fluid. Okay. Everyone clear so far? So basically the sort of day one part is the conservative fluid. That's don't give maintenance fluid, concentrate your drugs as much as possible. Don't think I mentioned that earlier. And only give IV fluid boluses if there's one of these objective signs of hypovolemia. And then next slide, we've got the deresuscitation part. So are there signs of fluid overload? Is there cardiovascular stability? And if both of those criteria are met, then go ahead and give the deresuscitation. We've also got a box here with some troubleshooting. So things that might happen, metabolic alkalosis we know can occur with diuretics, and we would suggest adding acetazolamide, 500 milligrams IV 6 hourly to help with that. And hypernatremia, we would suggest that you continue the diuretics per protocol and then just add some free water as required. You can also consider increasing the thiazide dose because that'll help remove fluid. And often these patients are, they're generally sodium overloaded as well as water. So the diuretics will preferentially offload water rather than sodium, which is why the concentration of sodium goes up and the patients become hypernatremic. So essentially by giving some water and also trying to remove some extra sodium to thiazide, you can generally manage that hypernatremia okay. I see a question from Natalie.
Yeah, hiya. So I was just thinking, would it just be almost easier to put them on our fluid restriction flow chart then? Because in Kettering we have a set thing for fluid restriction that you wouldn't even put it in sodium if you could get away with it. So if someone's not diabetic, for instance, just to use glucose as opposed to sodium. And obviously with restricting the fluid, we're not then overloading said patient. So would it just be easier for me to sort of pitch this to my doctors to say, like, if the patient's on this arm, aim for the fluid restriction sort of protocol, because then our nurses will know what they're doing as well. Would that make sense?
Yeah, if it's compatible with protocol, then yes, that sounds fine.
Okay, cool.
At least for the conservative fluid part. And then obviously the deresuscitation part needs a bit more direction, I suppose.
Yeah, absolutely. So obviously with like deresuscitating, it's fine. But my impression was, I think you just answered it there, was with regards to medications, because that's where most of our patients' fluid comes from. But you have just said to reduce that. So yeah, I think fluid restriction at Kettering would be a good idea. Thank you.
Yeah, sounds good. And yes, that's right. So the fluid restriction, the restriction in drug volumes is probably best done according to local policy. So if you have a policy that says your peptaz goes in 50 mils minimum, then stick with that. If you can reduce it, great, but that won't be possible for everybody. So you can use local judgment on that. Grace?
Apologies if can you hear me?
Yep.
Cool. Apologies if you've already mentioned this, but I was just looking at the protocol. If there's someone who has developed a hospital-acquired sepsis, are they included in this trial?
So if I remember correctly, it says first episode of admission to ICU with sepsis. Janice, tell me if I'm talking nonsense.
Yep, no, that's correct.
Okay.
Okay.
So yes, if they're provided they haven't been in ICU before with sepsis, that's fine.
Yeah.
All right. Thank you.
And did I see another hand, or did I imagine that? Maybe it's a historical one. Okay. Okay, so hopefully that's all reasonably clear. We'll move on to the next slide. I think we've said all this already, to be honest. So we're aiming for liter a day negative balance, and that's the combination. So 0.25 milligrams per kilogram as a bolus, followed by the infusion. And we suggest starting at 5 milligrams an hour and titrate it. And you might find that you need it for, 4 hours, or you might need it for the full 24 hours. It'll vary between patients. I would suspect you may well often end up turning this off. I think that's what happened in the pilot, if I remember correctly. So, and that's fine. It's done its job. You can stop, provided you've hit at least the litre a day target. Next slide. Okay, so standard care is just standard care. You do what you would normally do, including the fluid boluses, maintenance fluid, standard drug dilutions. I suppose one thing we would like not to see is contamination between arms. So if, to take the example that I think it was Natalie maybe mentioned about fluid restriction. So if you have a protocol for that, great, use it in the intervention group. But we don't really want to see that contaminating the standard care group as well. Otherwise, we haven't got a trial anymore. Yeah, we would like you to do as you normally do. You're allowed to use diuretics if that's what you normally do. That's fine. We'd like you generally not to target a specific negative fluid balance unless there's a clinical indication to do so. Okay, next slide. So this is really just the visit schedule. So I'm not going to really go into that unless anybody wants me to. Nope, I'll skip. And okay, yes, some FAQs. So these are things that have come up. So what if the patient is in the conservative arm and the treating clinician thinks the patient requires more fluid? So as clinicians, we are notoriously bad at this. We're very bad at letting go. We think we know. And a lot of the time, if we're honest, we don't. We have developed ways of working around our lack of knowledge. So I have my criteria for thinking a patient looks a bit dry or a bit empty or whatever you want to call them. And my colleague next door will think something completely different. So that's why we've specified objective signs of hypovolemia. And really they're really not even just signs of hypovolemia. We're talking hypovolemia with hypoperfusion. So there has to actually be a problem to treat. So just thinking a patient looks a bit empty or looks a bit dry, not really good enough. There needs to be something objective. So you remember those criteria, which were the elevated lactate over 3, skin modeling, and blood pressure target, which can't be maintained despite up-titration of noradrenaline or other drugs. And then on day 1, then we've got the urine output criterion as well. Having said all that, if a patient is really unwell and someone really believes that this is the right thing that the patient really needs, then obviously the patient comes first. Okay. What if the treating clinician doesn't want to follow the conservative resuscitation, deresuscitation fluid flowchart? Well, you can't make people do it. We would like to know about it. We'd like to know why. And I guess some gentle challenge can sometimes be appropriate. You'll know when that's a good idea and when it's not on your own sites. I would stress that we have demonstrated safety and some of the concerns around cardiovascular stability and AKI, for example, with diuretics, are not borne out by evidence. And I'm happy to provide supporting evidence if needed. But yes, if it does happen, please record it and let us know why, and fill in a protocol deviation form. Thanks. What do we report as protocol deviation? Do we want to know about every fluid bolus that's given? No. So we accept that this is a pragmatic trial. We accept that in 60 sites across the UK, we cannot keep tabs on every fluid bolus and every single thing that happens. So we would like you to monitor it yourselves, keep an eye on it, re-educate. We're happy to provide resources for that if you need us to. And really, we're looking for the difference between the two groups on average. So we will look at adherence by looking at the diuretic use, but we can't see your patient, so we can only use the criteria that are reasonably accessible to us. Okay.
Okay,
Right.
I think that's Paulina now. So thanks for that, John. I think Paulina now is just going to run through how to enter some of the data, and then we'll come back for some questions. Unless anyone has any questions for John now. No?
I'll
Okay.
step in now.
Yeah, go ahead.
So this is what your randomization assignment form will look like when you have randomized to the fluid intervention. So if a patient is randomized to the conservative fluid therapy, this is the outcome on the randomization assignment form. And if you click next, Dennis. So the baseline form, which you will complete on the day that the patient is randomized, will ask you for the total fluid given in the previous 24 hours. So if you click again, Janice, so when we're asking for total fluid, we're asking for all IV, nutrition IV fluid, drug volumes, and blood transfusions should be all included in this total fluid given. Next slide. So your daily data forms, we're asking you to enter the fluid given over, because the protocol states for 5 days, you will be entering this data for 5 days. So the daily data forms are essentially the same every single day for 5 days. And as you can see here, you have the total fluid input in the last 24 hours, which once again is including all IV, drug volumes, transfusions, etc. And then you have the total fluid output, which includes the urine RRT and drain outputs. As you can see here, the grey box is auto-calculated. So the daily fluid balance is auto-calculated for you, and the cumulative fluid balance is also auto-calculated. And that translates from day 1 to day 2, and then day 2 to day 3, and so on until day 5. So here is a day 2 screenshot. As you can tell, the daily fluid balance is auto-calculated, and then the cumulative fluid balance is the total from day 1 and 2. So all we would ask you is to input the total daily fluid input and output, and everything else is auto-calculated on the on OpenClinic or on the database. So yeah, if you can just input that data from day 1 to day 5, continuing on until the protocol is over. Yeah.
Okay, great. Thanks for that, Paulina. And now I think I'll hand over to Ravi for a few study updates.
Thanks, Janice.
We have a question first of all.
Oh, sorry, Grace, go for it.
Thank you. Super quick question. When we're entering the data, do you have a specific time point in which the days start and end?
Good question. So we are obtaining clarity from this from memory. I believe we are happy with ICU day. So because usually your ICU chart will calculate from that day, whether it's 8 a.m. or from sort of midnight to the end of the day. So your dailies, so from your day 1 onwards, you can use your ICU chart, and then your baseline is from 24 hours prior to randomization. So for that, if you have that data, whether they were in A&E or whether they're in the ward before, we'd like the 24 hours prior to randomization. But yeah, from day 1 onwards, we can then use the ICU chart day.
Amazing. Thank you.
No problem. Here we go. Back to you, Ravi.
Natalie's got a question. Natalie.
Hi, yeah. So just with the fluid, the thing that I've found with the last 2 patients that we've randomized is when they go to the wards, obviously fluid balances aren't calculated quite as well as they would be on ICU. So the struggle I'm getting is, what do I put in? Because I've had to put a comment saying not really available.
Yeah, this is the challenge, I think, Natalie. And
Yeah.
when we move on to the ward, we do realize that some of that is out of our control.
Of course.
So we would just say, do what you can.
Okay.
It's great that you're adding comments too, just to explain, you know, if there are some sort of gaps in the fluid. But yeah, I think that's all we can do is just enter the data that you
Okay.
have, and yeah, we'll review the comments as they come in.
Yeah, that's fine. Thank you so much.
No problem.
Okay. So we just have a few study updates they're more applicable for our sites that are currently open to recruitment. So we've circulated a file note tracker to all of our open sites. This is just after a recent audit. We were advised that we should be using this for our site. So any file notes that you create, if you can ensure that they're numbered, and then make a note of them all on their tracker so that you can easily see which file notes have been generated for the study for your site. Today is also the last day for randomization before the August bank holiday. So I think some of our newly open sites, it might be a bit confusing, but it's because the college is closed on bank holidays, which means our central lab is closed. So this is why we just pause recruitment over bank holidays to ensure that there's not too much of a delay in getting your PCT results. You can begin recruitment again on Monday, and the lab is open from Tuesday to start analysing the samples again. And just because we've had a couple of queries for when people randomise a patient on Open Clinica, so apologies for any inconveniences that anyone's had. So when you randomise a patient on Open Clinica, first you complete the randomisation confirmation page, and then you come out of that form and go into another form called randomization confirmation, which shows you the intervention. Sometimes it takes a minute just for the intervention to show on that page. So we advise just to wait a minute when you've completed the confirmation page before going on to the assignment page. If still it's not showing the randomization intervention, don't panic. Just come back out. And then before going into the form, there are some 3 dots on the side of the form, which you can click edit, and that kind of resets the form, and it gets the information from our randomization system, and then that information immediately appears on the form. But if you do have this issue where you're not seeing the randomization allocation and you're a little bit worried, just send us an email, mark it as urgent, or give us a phone call, and one of the team can just talk through on the phone and just reassure you of how to do it. But yeah, it's just due to a bit of a database lag. Yeah, Julia? Question?
Hello there, Julia from Nottingham QMC. We're in the very, very early stages of this trial, so we're not open yet. But it was just found it interesting that you're closed till bank holiday, till the Tuesday now, over bank holiday. We cover a 7-day week, so does that mean that recruitment over weekends isn't possible for this trial? Is the lab open over weekends? Or
Yeah, so we do allow recruitment over weekends. It's just because due to the bank holiday, it just kind of extends the weekend, and we don't want a sample, especially a PCR sample, to be waiting for us. And it kind of getting stuck and a site team waiting for the results.
Okay, that's great. Just wanted to check that. Thank you.
Okay, no worries. Does anyone else have any questions about any of the study updates? Sally?
Hi there. Sorry, I just wanted to check what your turnaround time is working out at for the PCRs.
So our turnaround time has improved quite a bit as we've changed our process recently. So we now have 24-hour tracked labels, which can be sent directly to our central lab. So we usually get the samples around the next working day or the day after. So it's 1 to 2 working days. And on
And
the
then-
day that we receive the sample, the samples are analysed. On that day, you'll get the initial report by the evening, so about 5, 6 o'clock. And if your PCR is positive, you'll get the second report by the next day.
Brilliant. Okay, that's lovely. Thank you.
No worries. Are there any other questions about the study updates? And just to say that our next webinar is planned for Wednesday, the 18th of September. So the next webinar is going to focus on the GM-CSF part of the study, but we will still use the end of it just to relay any important study updates, or you can always come and ask questions about any aspect of the trial as well. Ashley? Yeah.
Hi, Ravi. So very quickly, in a GSE himself, the placebo, what's the content of the dummy drug we use? Normally, it's not written in the protocol.
What's the content of the placebo?
Yeah.
I can find out for you. It will be detailed in our IMP guide, but I can pull it out and send it through to you.
Yeah, thank you.
Yeah, no problem. Just might take me a minute or two. Any other questions in the meantime? No? Okay. I'll send that through by email, Ashley. And if there's nothing else, thanks everyone for joining. I hope that's been helpful. We'll pop the recording on the website for anyone who's missed it, or if you just want to refer back. Let us know if you need anything in the meantime. I know it's been a little bit quiet with annual leave and such, but when your teams do return, if you need anything from us, do let us know. And hopefully we'll see you all at the next webinar.
Thank you.
Thanks, everyone.
Thank you.
Thanks, everyone.
Thank you. Take care.
So,
Bye.